Hello, this is Robert Lee, and this is a brief video on active surveillance for localized prostate cancer. To begin with, I want to define a few terms. You will hear the terms watchful waiting and active surveillance in the literature, and they don't mean the same thing. Watchful waiting, specifically, the goal is to avoid any form of treatment. No definitive treatment is recommended, and any treatment is delayed until the patient develops symptoms. And should the patient develop symptoms, then and only then is treatment initiated. Active surveillance, on the other hand, the goal is to try and intervene only at the time of progression. There are triggers based on preset criteria, and basically it involves close monitoring, the frequency of which has not been well established. So fundamentally different. Watchful waiting is no treatment until symptoms develop. Active surveillance is monitoring the patient, and if there is progression, intervening, usually with definitive therapy at that point. The rest of the slides will focus on active surveillance. I will look at two large cohort studies, one from Toronto and one from Johns Hopkins. This is the Toronto cohort, begun in 1995, nearly 1,000 men, reported now for about 5 years ago. The eligibility criteria changed slightly in that initially low-risk disease was allowed and intermediate risk disease was allowed if you're over the age of 70. These criteria were modified in 2000. And Gleason 7s were only allowed if you had a life expectancy of less than 10 years. The most recent update has a follow-up of about 6.5 years. These are the patient characteristics. You can see median age of about 68. The majority of patients had low-risk disease, but there were a few men with intermediate risk disease. This is the protocol used in Toronto. PSA was monitored every 3 months for 2 years, and then 6 months, Q6 months thereafter. Repeat biopsy within the first year, and then every 3 to 4 years after until age 80, at which point biopsies were stopped. The initial decision on whether to biopsy was made after 6 months and 3 PSAs to calculate a doubling time. And initially, PSA doubling time was used as a trigger, but when they looked at their data, they decided not to use doubling time as a trigger and to use progression, be it to more cores or Gleason 7 or change in the digital rectal exam. All in all, about a quarter of men ultimately received some form of definitive treatment. The likelihood of being treated was related to Gleason score, baseline tumor category. Multivariable analysis basically suggested that the Gleason score was predictive for intervention. This is the cancer-specific survival for the entire cohort. 6% of men died at 15 years of prostate cancer. Again, this is active surveillance. A more recent update looking at metastasis-free survival found that Gleason score was predictive, as was doubling time, and the number of cores on the first biopsy were predictive for the development of distant metastasis. The other study is the Johns Hopkins cohort, begun about the same time. More men, about 1,800 men. Johns Hopkins was much more strict in their criteria. They developed a very low-risk category, which you can see defined on the right, non-palpable disease, a low PSA density, no more than 2 cores involved, and less than 50% involvement of any core. They did also allow low-risk patients. Follow-up about 5 years in the most recent update. They monitored them with a PSA and DRE every 6 months with an annual biopsy. They started doing multiparametric MRIs in 2013. Their triggers for treatment were slightly different than the Toronto group. Upgrade to a Gleason 7 or greater, more than 2 cores, or more than 50% involvement. They specifically forbid serum PSA and kinetics used as triggers. This is looking at death. Most of the deaths are not related to prostate cancer. Only 4 cancer deaths in nearly 1,800 men. This is looking at the cumulative incidence of biopsy reclassification or receiving curative intervention. Within 10 years, about 50% of men received definitive therapy, which is about twice as much as is seen in the Toronto cohort. Part of this relates to the different approaches, and part of it relates to the different definition of progression. Now, those 2 studies are prospective, but they're not randomized comparing it to anything. We do have a randomized comparison of active monitoring, which is close to active surveillance, versus definitive treatment, which is the PROTECT trial, which will be covered in a later video. This is the NCCN guideline recommendations for active surveillance: PSA every 6 months, DRE annually. Prostate biopsies are done, your second prostate biopsy, relatively soon after your first if there are lots of cores involved or there's a discordance with the clinical examination, and then consider it annually. They recommended more rigorous surveillance in younger men without being explicit on exactly how that is. And progression is generally defined if you find any Gleason 4 or 5, increasing number or involvement of cores, and they did not provide a clear recommendation on PSA kinetics. So, to summarize, to the extent that active surveillance is a game, the rules of the game are slightly different depending on where the game is played, and that's why you'll see differences in the literature. Take-home points. Active surveillance is preferred in very low risk and low risk men, especially older men. It is appropriate in selected favorable intermediate risk patients, especially older men. How multiparametric MRI is going to be weaved into this is actively being investigated, and it's not yet been part of the standard of care, but many people are looking at how best to incorporate MRI findings into the active surveillance process. The definition of progression is different according to different protocols and institutions. I think it's fair to say that PSA doubling time is probably the least reliable. On the one hand, PSA is cheap and easy to get. On the other hand, it can be somewhat capricious, and many are not using PSA to the extent that they're using upgrading at the time of biopsy. The genomic tests are out there. They're actively being investigated to date. However, they really haven't been proven. And I'll end with this statement from the NCCN. Men with low or favorable intermediate risk disease may consider the use of some of the genomic tests, but it is yet to be accepted as a standard of care. Thank you.